Good evening. My topic is two of the abstracts in non-clear cell RCCs, and those two are. Next slide, please. Yeah, so the first is CABOSUN trial, which studied Cabozantinib, and the other one is the recent IO plus TKI combination, which we use in clear cell, now extrapolated to non-clear cell also by a trial, phase 2 trial. So as we know, the variant RCC histologies, it started with limited 3 or 4 classes subclassifications, and now it has evolved into 21 histology spectrum. Now also having some of the molecular markers driving the variant RCC histologies. And if we see the older data of management of non-clear cell RCC, it was primarily extrapolated from the use of TKIs in the clear cell RCCs, as we studied the use of Sunitinib, and we can see that the overall response rate was around 10 to 15% with a PFS of 5 to 8% and showing dismal prognosis. And if we compare the clear cell and the non-clear cell histologies by their outcomes with the use of TKIs, we can see that the non-clear cell RCC performed much worse than the clear cell RCCs in with the TKI use. But important thing to note was the chromophobe histology, which showed a relatively better prognosis. So this was the PAP-MET trial, which showed which had 4 arms having Sunitinib, Cabozantinib, Crizotinib, and the Savolitinib, and it showed a superiority of Cabozantinib in terms of PFS amounting to 9 months versus 5.6 months versus Sunitinib. And furthermore, extrapolating on that concept, there was a Savol trial which compared Savolitinib versus Sunitinib and which showed improved response rates and also outcomes. And then they used a IO combination with the TKI, which used Savolitinib with Durvalumab. And again, the response rate was better in the MET-driven patients. So clearly, we can see that now we are moving from a approach which was used blindly like the clear cell RCCs in the non-clear cell, and now we are moving towards a molecular approach, knowing what mutations are then, how we can target it. Then came the advent of immunotherapy, which the single agent immunotherapy agents, we could see that the response rates were about 20%. And going from that concept, there was this, going from that concept, there was this combination of TKI with IO, that is a Cabozantinib with Nivolumab combination, which had 2 cohorts. The first cohort was the miscellaneous non-clear cell RCC, and the cohort 2 was the chromophobe RCC. And we can see that in the cohort 1, which was a miscellaneous non-clear cell RCC, the response rate was 48% with the use of IO plus TKI. So the first abstract which was given to me was a CABOSUN 2 trial, which studied the Cabozantinib versus Sunitinib. It was a phase 2 study, and the dose modification of Sunitinib was allowed according to the tolerance, and the primary endpoint was PFS. Here we can see that the distribution of histologies was little aberrant between the 2 arms. The chromophobe RCC patients, the 5 out of 6 were in Sunitinib arm, while the MITF translocation RCCs were 3 of them, all of them were in the Cabozantinib arm. So there was some discrepancy in the distribution of the cases, and also this trial was stopped early due to the change in the practice, which was established by the PAP-MET trial, which showed that Cabozantinib works better than the Sunitinib. Yes, and PFS and OS did not show a significant difference. The response rate was if we can see the response rate, then there are more than 50% of patients in both the arms had stable disease. So half number of patients having stable disease in this arms in this trial, and the conclusion was that this trial could not be completed because of the already established superiority of the Cabozantinib in the PAP-MET 2 trial. Now moving forward, the second abstract, which was a use of IO plus TKI, what we do in the clear cell RCCs in the non-clear cell, that is a KEYNOTE-B61 trial. Here the histological confirmed diagnosis of non-clear cell RCC were included and randomized. They were given Pembrolizumab with the Lenvatinib TKI combination. 158 patients were included in the study. And the primary endpoint was the objective response rate. Yes. So the distribution of the patients. So 58% of patients belong to the papillary RCC and 18.4% of patients the chromophobe RCCs. And if we see the response rate according to histology, we can see that it is above 40-45% in most of the histologies except the chromophobe, which had a response rate of 34%. Yes, again the diagram depicting the same of the response rate according to the various factors. And at the initial paper readout, it was at 14 months, which showed a PFS and OS, the OS of around 82% at 1 year. And the recent ASCO GU 2024 readout, which a median follow-up of 19 months, it showed a PFS of 17.4 months in the papillary group versus 26 months in the chromophobe group, and the OS is mature data is awaited. The adverse events were consistent with the use of IO plus TKI, which we have seen earlier in our clear cell RCC practice. So there are two IO plus TKI combinations. That one is the Len Pembro and the Nivo plus Cabo. So we have a more the sample size of Len Pembro trial was a larger sample of 158 patients. However, the follow-up is of 19 months. Also, in the Len Pembro, the favorable risk constituted on 44% of patients versus 23 in the Nivo Cabo, and the PFS which we have is 17.9 months with Lenvatinib plus Pembrolizumab versus 13 months in Nivo plus Cabo. So this is the summary of the treatments and their outcomes in non-clear cell RCCs, how we have what we have achieved so far. So we can see that VEGF, the TKI and the IO combination seems to work the best out of all, followed by the Cabozantinib and the single agent IO drugs. And if we see the response rates according to the various histologies, we can see that in papillary RCCs, the IO plus TKI seems to perform better in the papillary RCCs like the clear cell counterpart. But in the chromophobe, we can see that there is some more role of Lenvatinib plus everolimus combination as compared to the IO TKI if we see just the response rates. However, the survival data is pending, but we know that chromophobe behaves in a better way compared to the other non-clear cell RCC histologies. So what is the next way forward? So there are current studies which are utilizing the combination of Savolitinib with IO. There are studies utilizing IO plus IO combination. There is another newer TKI which is used in Nivolumab along with Nivolumab. So where are we currently in non-clear cell RCC? So we have moved from a empirical TKI usage in non-clear cell RCC to a more personalized use of TKIs. We are moving towards MET-driven, MET-targeted molecules. We are adding immunotherapy along with TKI to improve outcomes, at least in the papillary and the miscellaneous group. However, a chromophobe histology remains a major challenge in which we need to see the we need to see the outcomes, how Lenvatinib and everolimus performs, and it is kind of a research desert. So until now, for non-clear cell RCC, we also need to see the other mutations like FH, in which the treatment again changes, in which we have option of Bevacizumab plus Erlotinib. Otherwise, we are we are good with IO plus TKI combination, which is being used in the KEYNOTE-B61 trial. Thank you. Apologies for this. I think there was some problem with the funds.